I would like to welcome all of you to this review of the IPF PEPPER, the PEPPER for Inpatient Psychiatric Facilities. My name is Kim Rahor, and I work for TMF Health Quality Institute. TMF is contracted with the Centers for Medicare and Medicaid Services, or CMS, to develop, produce, and disseminate the PEPPERs. Today, my presentation is going to focus on the most recent release of the PEPPER for Inpatient Psychiatric Facilities. It was completed just a few weeks ago. That would be the version Q4FY17. So today I'm going to be focusing on the most recent PEPPER for Inpatient Psychiatric Facilities. There have been a few changes that you're going to notice in this release of the PEPPER. We have discontinued 2 of the target areas that were included in the previous release. And on the outlier payments target area, we are now calculating the average outlier payment. I'll review a few other resources at the end of our presentation this afternoon. Now today is going to be a rather high-level review of the PEPPER, so for those of you who are new to PEPPER, you might feel that you have more questions than answers at the end of today's session. If after today's session you still feel like you need some additional training, I would encourage you to access the recorded sessions that are available on the Training and Resources page at pepperresources.org. There you can find presentations that are available in short segments. We'll be reviewing percents and percentiles. There's a demonstration PEPPER that's reviewed, as well as other sections that talk about the target areas and how they were identified and that type of thing. So I'll start off here. What is PEPPER? PEPPER is an acronym that stands for Program for Evaluating Payment Patterns Electronic Report. And basically, the PEPPER is a comparative data report that contains or summarizes one provider's Medicare claims data statistics for areas that might be at risk for improper Medicare payment, primarily in terms of whether the patient's treatment was necessary and correctly coded and billed. We refer to these target areas, these risk areas, as target areas, and we'll review those in a few minutes. In the PEPPER, we're comparing your facility's Medicare claims data statistics with aggregate Medicare data for other IPFs in 3 different groups: all IPFs in the nation, all IPFs in the MAC jurisdiction, and all in the state. These comparisons allow you to identify where your facility might be at a higher risk for improper payment, which just means that its billing practices are different from most of the other psychiatric facilities in the comparison group. I do want to stress that PEPPER does not identify the presence of improper payment. Those can only be confirmed through a review of the medical record, but PEPPER can give you clues as to where your billing patterns look different so that you can then determine if that's what you expect to see or if you might need to take further action if you might have some concern. A little bit about the history of PEPPER. PEPPER's actually been around for a long time. It was developed in 2003, originally for short-term acute care hospitals. At that time, it was provided through the state quality improvement organization. Then in 2010, TMF was contracted directly with CMS through the Center for Program Integrity Provider Compliance Group, and we started distributing PEPPERs to all hospitals in the nation, so all short and long-term acute care hospitals. And then TMF began developing PEPPERs for other types of providers. So you can see on this slide that the inpatient psychiatric facility PEPPER has been available since 2011. So why are PEPPERs available for IPF? Well, CMS is mandated by law to protect the Medicare Trust Fund from fraud, waste, and abuse. And many of us are aware that CMS employs a number of strategies to meet this goal, such as provider education, early detection through medical review, and data analysis activities. The provision of PEPPER to providers supports CMS's strategies. CMS considers the PEPPER to be an educational tool that can help providers identify where they might be at a higher risk for improper payment, so they can then proactively monitor and take preventive measures if necessary. I might also mention that the Office of Inspector General, or OIG, encourages healthcare providers to establish a compliance program to ensure that systems are in place to help protect their operations from fraud and abuse. And as part of a compliance program, a provider should conduct regular audits to ensure that charges for Medicare services are correctly documented and billed, and that those services are reasonable and necessary. So the PEPPER can support that goal. Let me move on now and focus more directly on the most recent release of the PEPPER. So those of you that are familiar with PEPPER know that each time we produce a PEPPER, we refresh the statistics for all 3 years that are included in the PEPPER. So this year's PEPPER includes statistics for fiscal years 2015, 2016, and 2017. We do roll off the oldest fiscal year as we add the new one on. And if you compare this year's PEPPER with last year's PEPPER, it's possible that you might see some small differences in numerator or denominator counts for the target areas. And again, that would be because we refresh all of those statistics from the paid claims database. And so any late claims that were submitted, any corrected claims, those would be taken account in the new release of the PEPPER. So you'll see those small differences in your statistics. So let's talk about improper payment risks that are pertinent for inpatient psychiatric facilities. Again, remember, the PEPPER doesn't identify improper payment. Those can only be confirmed through a review of the documentation in the medical record to support treatment and the diagnosis and procedure codes that were submitted on the claim. IPFs are reimbursed through the IPF PPS, and just as in other inpatient settings of care, IPFs are at risk for unnecessary admissions and incorrect coding, which can impact correct reimbursement. Now, when we originally developed the target areas for the inpatient psychiatric facility PEPPER, there was limited information available from actual medical record reviews, so we based those initial target areas by reviewing the IPF PPS and focusing on those areas that could be prone to improper payment. We also analyzed national-level claims data, and then over the years, we've coordinated with CMS to develop the target areas based on what they see as potentially at risk for improper payment. All of the target areas in the PEPPER are constructed as a ratio where we have a numerator, which basically is the discharges that are identified as potentially problematic, either from a medical necessity or coding standpoint. And the denominator is a larger reference group. For each of our target areas, we calculate a target area percent. Essentially, we're dividing the numerator count by the denominator count, multiplying that by 100 to come up with that target area percent. And you'll get a feel for what that looks like when we actually take a quick look at the PEPPER. Now I'd like to quickly look over or review the target areas in this most recent release of the PEPPER. There haven't really been any changes in these target areas. The 2 target areas that were removed were removed. I'll talk about those in actually just a minute. So first of all, on this screen, you'll see we've got 3 target areas listed. The comorbidities target area is the only target area that's focused on the possibility of coding errors. And coding errors can go 2 ways. The IPF can upcode, in which case it receives an overpayment, or the IPF can undercode, in which case the IPF may be not reimbursed sufficiently for the care that they provided. In the comorbidities target area, we're looking at the percentage of claims that have at least one comorbidity on the claim. IPFs do receive payment adjustments for a number of comorbid conditions. When IPFs have a high percentage of patients with comorbidities, it could be an indication of potential overcoding. Likewise, as I just mentioned, if you've got a very low percentage of patients with comorbidities, it could be an indication of potential undercoding. Now, I'll stress here that given your patient population and the characteristics that may be unique to your facility, you may expect to have a high or a low percent for this particular target area. So consider that when you're interpreting the statistics in your PEPPER. You may expect to be high or low, and if that's what you expect to see, then it's probably not a concern. The second target area, no secondary diagnoses. Here we're calculating the percentage of claims for discharges where there are no secondary diagnoses coded. Just a reminder, the claims should include the appropriate selection of the principal diagnosis as well as other additional and coexisting diagnoses. These may not necessarily be psychiatric diagnoses, but they could be for any active medical condition. The coding guidelines specify that all of the patient's coexisting or additional diagnoses should be reported on the claim so that there's accurate information regarding the beneficiaries receiving services. If you don't code all of those secondary diagnoses on the claim, you also may not be capturing those comorbidities, and again, it could affect your reimbursement. The outlier payments target area, here we're calculating the percentage of total Medicare reimbursement comprised by outlier payments. So this is based on dollars. IPFs that have a high percentage of dollars comprised by outlier payments might wish to look at those cases, at their outlier payments, to ensure that care was medically necessary and that the claim was correctly submitted. You also might want to check out your admission and discharge policies in conjunction with this review. And this is the target area for which we're now calculating an average outlier payment. We'll take a look at that in the PEPPER. The last two target areas that are included are really more focused on readmissions. The 3 to 5 day readmissions target area is calculating the percent of patients that are readmitted within 3 to 5 calendar days or 4 to 6 consecutive days. Here we're wanting to assess the risk for potential circumvention of the interrupted stay policy, where patients readmitted within 3 days or 3 consecutive days from discharge are treated as a continuation of the initial admission for reimbursement purposes. 30-day readmissions, as many of you know, CMS has been focused for a while now on reducing readmissions across many settings of care. So we have included in the IPF PEPPER a readmissions target area. And both of these target areas that are looking at readmissions could also help assess the risk for premature discharge. Now, I mentioned that we've discontinued 2 target areas, no ancillary charges and 1-day stays. I'll give you a little rationale for that right now before we move on. About 19% of the IPFs had reportable data for the no ancillary charges target area. And when we looked more closely at those 19% of IPFs, almost all of them did not submit any claims that had ancillary charges. So what that meant was that 81% of the IPFs submitted claims that had some ancillary charges as expected. So the concern for unbundling regarding ancillary charges might best be monitored by other contractors. And so we felt like it was time for us to remove it from the PEPPER, and CMS concurred. On the 1-day stays target area, there were only a small percentage of IPFs that had sufficient data to report statistics for this target area, about 4%. And so again, we looked at it on a broader level and recommended that it was time to retire that target area as well. Now, I would encourage all of you listening today to continue to monitor the short stays, the 1-day stays, as well as making sure that you're submitting ancillary charges as expected, Just because they're not risk areas in the pepper anymore doesn't mean that they're off the radar. Just a note about the comorbidities, the codes that, or the diagnoses that qualify as comorbidities are always included in the final rule. And so you can find those categories, the information, at the link that I've included here on the slide. And you also can find that information in our PEPPER User's Guide. Before I go into the review of a PEPPER, I always like to give this little, or include this slide in my presentations, which sort of helps people get geared up in their mind for how we calculate percentiles and what that means in the PEPPER. We use the percentile value to identify outliers for each of the target areas. So if you're a high outlier for a target area, that means that your target area percent is at or above the national 80th percentile. If you're a low outlier for the comorbidities target area, that means that your target area percent is at or below the national 20th percentile. And percents and percentiles can really be complicated for some people to understand. So here what I've done on this slide is we have a ladder. And associated with each rung on this ladder, we have a target area percent. Now let's just say it's the target area percent for all hospitals in the nation. I know there's only 10 values here, but you'll have to just imagine there's a whole bunch of numbers, percent. We've sorted those target area percents from highest to lowest. So we have all the IPFs, all of their target area percent sorted from highest to lowest. We identify the target area percent below which 80% of the providers fall. And that percent is identified as the 80th percentile. So essentially the top 20% of the providers in this distribution are at or above the 80th percentile, and so in the PEPPER they're going to be identified as high outliers, and you'll see your target area percent in red bold print. Now on the flip side, when we're looking at low outliers, we're talking about the percent of providers that are at or below the 20th percentile. The 20th percentile is that point below which 20% of the hospital or the inpatient psychiatric facilities percent falls. So again, it doesn't really have, what the percentiles do, they help provide context so that you can understand where in this distribution of target area percent you fall and how different you are from the rest of the providers in the comparison group. Okay, I think now is a good point for me to move into a quick review of the PEPPER for inpatient psychiatric facilities. The PEPPER, again, is a Microsoft Excel workbook. It is distributed electronically. And when you get your PEPPER, and you open up the Microsoft Excel file, this is the first page that you're going to see. You'll see your provider's name and your CMS certification number, your provider number here. The purpose page is going to identify for you the most recent quarter of statistics that are included in the PEPPER. So this one is through the fourth quarter of fiscal year 2017. You would see your jurisdiction comparison group here. The jurisdiction comparison group is basically comprised of all of the other IPFs that submit their claims to the same MAC, or Medicare Administrative Contractor, as you do for Medicare reimbursement. Now the PEPPER is a Microsoft Excel workbook. You'll navigate by clicking on the worksheet tabs that are along the bottom of the screen. We do include in the PEPPER a definitions worksheet where you can find the complete numerator and denominator definitions for each of the target areas. We felt like this was a handy way to make sure it was easy for you to figure out when you're looking at your data, what does this numerator include? What does this denominator include? So we have all of that for you on the definitions tab. The Compare Targets report is a nice report to review. I always suggest that people look at it first thing when they get their PEPPER. The Compare Targets report is the only place in the PEPPER where you can see your statistics for all of the target areas for which you have sufficient data to report, all in one view. Now it is only representing the most recent fiscal year, so this is for fiscal year 2017. But this is where you can look and see at a quick glance any target areas that you would be a high outlier in which case your target area percent would be printed in red bold print. If you're a low outlier, this hospital is a low outlier for this target area, or if kind of in the middle of the road. So for each of the target areas that you have reportable data, we include a brief description of the target area. Here you're going to see your numerator count. And this is going to be, like for the comorbidities, this is the discharges that had at least one comorbidity coded on the claim. The denominator value is not included on this report, but it is on the specific target area report, which I'll cover in just a moment. When we divide the numerator by the denominator, we get our target area percent. So this IPF's target area percent for comorbidities is 11.1%. I want you to think back to that ladder that we just had on the previous slide. So we're plugging our 11.1% in along with all of the other providers in the nation where, and we can see that on this national percentile value for this provider is 4.4. So what that means is that in that whole distribution from highest to lowest, this hospital's target area percent of 11.1% is greater than only 4.4% of the IPFs in the nation. So it's way at the bottom in that whole distribution of target area percent. So this IPF might expect to be low in the comorbidity measure for their patient population or for other reasons. But if that's something that when they look at these numbers and they think, not sure if that's what I would have expected to see, then we can talk about perhaps looking at documentation, medical records, seeing if the coding, if the medical records diagnoses and procedures are coded properly and that type of thing. Because they've got a very low national percentile. When we compare them to all of the IPFs in their jurisdiction, they're at the 5.3 percentile. So this means when they're just comparing themselves to that smaller group of IPFs in their jurisdiction, 5.3% of them have a lower target area percent than we do. And then in the state, again, a smaller group still, 6.7% of the IPFs have a lower target area percent. Now we'll typically see differences in the percentiles for nation, jurisdiction, and state because you're being compared to a different set of hospitals, a different set of IPFs. Something else that I might point out, and this may be more discernible for some target areas than others, but sometimes there are regional differences in the way that treatment is delivered. And so sometimes you can see those types of differences when you're looking at jurisdiction or state as opposed to nation. The other comment I'll make before I move on is that these are your IPF's exact percentiles, and this is the only place in the PEPPER where you will see your exact percentiles. The last column here is the sum of payments. This is the total amount of Medicare reimbursement that the IPF received for these 89 discharges. And sometimes the amount of reimbursement can be helpful in deciding or prioritizing what target areas you might look at first. I would encourage you to think about the target areas for which you have the highest percentile, in particular if that's not what you expect to see, and that have large amounts of Medicare reimbursement. I'll move on now to talking about the target area reports in the PEPPER. They are all constructed or formatted in the same manner, so once you get used to looking at them, it's pretty easy really. Your eyes are probably first drawn to the graph that is up here at the top of the screen. We display your hospital's, your IPF's target area percent over the 3 fiscal years as these blue bars. So you can see how your target area percent might be changing over time. And so this IPF was already low a couple of years ago. It looks like they were right at the national 20th percentile, and then their comorbidities target area percent got a little bit lower and picked up just a smidgen most recently. So the questions that this provider might be asking themselves is this what I expect to see in my target area report for my statistics related to comorbidities? Have we had any changes in the staff, perhaps that document or who assign the codes or who submit the claims for those that include those codes? Is that something that we might need to look at? Of course, if this doesn't raise any alarms for you, if you think that it's reflecting what you expect to see, then probably no further action is necessary. I will mention, I think I already mentioned, so these 3 trend lines here are the 20th percentile for our 3 comparison groups. The solid green line is the 20th percentile for nation. The dashed line is the 20th percentile for jurisdiction. And the dotted line is the 20th percentile for state. Now, on the other hand, we also include these 3 red trend lines, which represent the 80th percentile for nation, jurisdiction, and state. Now, below the graph, we include a data table where you can find your statistics. So here is going to be your target area percent over the 3 time periods. If you're a low outlier, you'll see green italics. If you're a high outlier, you'll see red bold font. This is going to be your numerator count, your denominator count. We also calculate for you the average length of stay for the numerator discharges and the average length of stay for the denominator discharges, as well as the average amount of Medicare reimbursement for the numerator discharges and the total amount of Medicare reimbursement. So this is nice detail that you might find interesting depending on your perspective and how you're looking at your PEPPER. Then below the facility data table is this comparative data table. This is identifying the target area percent that is at the 80th percentile for nation, for jurisdiction, and state. And then for this target area, we also identify the target area percent that is at the 20th percentile for nation, jurisdiction, and state. And these are the values that are represented by these trend lines up here in the graph. And lastly, on all of our target area reports, we include some very generalized suggested interventions. If you were a high outlier for this target area, what might that mean? What might you want to do? Similarly, if you were a low outlier, what could that mean and what next steps might you want to take. This is the target. This is the sample provider's target area graph or report for no secondary diagnoses. You can see this provider has a very low percent of claims that don't have any secondary diagnoses. For outlier payments, this provider actually only has sufficient data to report statistics for 2 of the time periods, the very oldest, and the percent here is so small it's barely discernible. And then for the most recent fiscal year, you can see the target area percent is pretty low. When there are fewer than 11 discharges that have outlier payments, we have to suppress the statistics for those target areas. Now, new for this report this year is we have added the average outlier payment amount. Last year, we didn't have any dollar values for this target area because we already had the total amount of the total outlier approved amount. We're comparing that to the total Medicare reimbursement amount. But it was suggested last year that perhaps we consider calculating the average outlier payment amount because that could be a helpful piece of information for providers. So we have added that this year. And I might mention, too, that you can use some simple algebra to figure out the number of discharges that had outlier payments. So, for example, here, I'll just do this directly in Excel. If we divided the total amount of outlier payments, 200,405, by the average outlier payment amount, 646.5, that totals out to be basically 31 discharges that had an outlier payment. So if that's a piece of information that you might find helpful, you can always calculate that using, again, some simple algebra. Just thought I would point that out there. Some of you might find that helpful. Okay, so then we've got the other couple of target areas that are focused on readmissions. This particular target area graph, we can see that the provider's target area percent was really high for that oldest time period, and then it's come down over the most recent couple of years. Whenever providers see changes, drastic changes in their target area percent, whether that be they go from high to low or low to high, I always encourage them to think about what might be some of the factors that resulted in those changes. Perhaps this provider identified some concerns related to their 3 to 5 day readmissions. Perhaps they implemented some changes and were able to make some improvements based on that. So this would be one way they could validate the efforts of their improvements were fruitful. But again, if you see something in your PEPPER that doesn't look usual, I would encourage you to look more closely. And here for 30-day readmissions, this provider's target area percent is below the 80th percentile for all 3 of the comparison groups. And actually their percent has come down a little bit in the most recent year, so doesn't look alarming for me. A couple of other reports that we include in the PEPPER that are supplemental in nature. These are simply for your own information. They don't have any impact on your risk for improper payments or outlier status in your PEPPER. This report here is identifying for you the top DRGs for the most recent fiscal year. So this DRG, the DRG number, the DRG description, the total number of discharges for that DRG, the proportion of discharges for each DRG to total discharges, and then the average length of stay for that DRG. We will include up to 20 DRGs in this list. However, if there are fewer than 11 discharges for that DRG, then we cannot report any information at the DRG level. Below here is some summary information for the top DRGs that are listed, and then for all DRGs. And we provide the same type of information at the jurisdiction level. Up here in the heading, you would see your jurisdiction, your MAC jurisdiction's name. And so these statistics would reflect or represent all of the IPFs in that MAC jurisdiction. And it would provide, again, the same type of information, the DRG number and description, total number of discharges, the proportion of discharges, and we include not only the average length of stay for the jurisdiction, but also the national average length of stay. So that was a quick look at a PEPPER. I hope that that was helpful for some of you. All right, I think I'll go ahead and move on. So sometimes when providers have access to their PEPPER, they are asked if they have to use their PEPPER, if they should be taking any action based on what their PEPPER statistics reflect. And the answer is to both of those questions is no. You don't have to use your PEPPER, and you certainly aren't required to take any action as a result of the statistics in your PEPPER. I always encourage providers to think about the PEPPER as a tool, as a high-level roadmap that can help you with identifying when you might be at a higher risk for improper payments, or when simply your statistics look different from the majority of other providers. Just a reminder that there are other federal contractors that have access to the entire paid claims database. They're mining the data. They're trying to identify providers that might be aberrant for case reviews or educational intervention. So the PEPPER can give you a heads up as to whether your statistics look different, and then you can investigate if you feel that's necessary, or if you feel that the statistics look right, then you're just aware that you look different. So do consider using this free report that's provided by CMS as one of your compliance tools. How do you get your PEPPER? All of the PEPPERs for inpatient psychiatric facilities are distributed through QualityNet. QualityNet is a secure distribution system that was developed by CMS for the reporting of hospital quality data. The hospital's QualityNet administrator can download the PEPPER. That person is usually involved in submitting the hospital's quality data. So if you know who your QualityNet administrator is, then you might want to just touch base with them and make sure they know to download the PEPPER and forward it on to you. If there isn't a QualityNet administrator at your hospital or IPF, you can contact the QualityNet help desk for assistance. Just a reminder that once we upload the file, the PEPPER file, it's available for 60 days from the date we uploaded. We can re-upload it, though, if necessary. Just contact us through the help desk. We can't, unfortunately, send the PEPPER through email. The PEPPER does contain hospital-specific sensitive data, so we have to handle it carefully. And we do plan to distribute the PEPPER on an annual basis. We'll be making those distribution timelines. We'll post them on the website and communicate with them with the provider community as that information becomes available. Once you receive your PEPPER, if you see a lot of red or green in your PEPPER, the first thing I want to stress is for you not to panic. Just because you're an outlier in a target area doesn't necessarily mean that you have any compliance issues going on. Remember, by design, there are going to always be 20% of the IPFs identified as a high outlier, and 20% identified as a low outlier for that comorbidities target area. So just remember, it's claims data, and we're comparing you with everybody else, so it doesn't necessarily mean that anything's going on. But I do want you to think about why you are an outlier and ask yourself these questions that we've covered today. Do those statistics reflect your population and your operation? Do you have any specialized programs or services that might affect the way your numbers look? Referral sources, anything in the external healthcare environment area. So just think about all the things that could affect your data and keep that in mind. The bottom line is to ensure that you're following the best practices, even if you're not an outlier. We have made available on our website aggregate data for all of the target areas as well as the top DRGs. Every time we put together a release of the PEPPER, we refresh these statistics that are on the pepperresources.org website. You can find them on the data page. We have national level data for all of the target areas and for the top DRGs. Also, we put together a separate workbook that is at the state level for the target areas and for the DRGs. Also, we have split out for the IPFs at the national level, recognizing that there could be differences in practice patterns for freestanding IPFs versus those that are units of acute care hospitals. We do provide a couple of additional reports, one that aggregates all IPFs that are freestanding, and then one that looks at all of the distinct part units. So you can take a look at some of that information if that's of interest to you. And we do update those following each report release. A couple of years ago, we also started putting together peer group bar charts. A long-standing request, mostly from short-term acute care hospitals, but they have wanted to be compared to their peers, what they would consider their peer. And so we put together these bar charts, and basically for each of the target areas, we are identifying the 20th, the 50th, and the 80th national percentile for IPS in 3 different categories. So we're looking at size, which is based on the number of discharges, location, urban versus rural, and also ownership type, for-profit or physician-owned versus nonprofit, church-owned versus government. We do update these peer group bar charts annually, and there are a couple of resource documents that go along with the peer group bar charts that I would encourage you to take a look at. They're not lengthy. There is a methodology document that explains how we put together these groups. And there's also an IPF by peer group file if you're interested in seeing in what categories your IPF has been categorized. Occasionally, organizations do not agree with their ownership type or location. Excuse me. We get that information from the provider of services file, which is maintained by CMS. So if you disagree with your ownership type or location, contact your CMS regional office coordinator to see if you can get that updated. I've included here on this slide an example of one of the peer group bar charts. This is for the outlier payments target area. You can see that in this top chart, the blue bars, the smallest 1/3 of IPFs have the largest or have greater values for the 80th percentile, the 50th percentile, and the 20th percentile. The middle 1/3 in terms of discharges has somewhat lower, 80th percentile, 50th, and 20th percentile. And then the largest 1/3 of the IPFs have the lowest, 80th, 50th, and 20th percentile values. If we're looking at location, which is the middle set of bars, the rural IPFs tend to have higher 80th, 50th, and 20th percentiles than the urban ones do. And then ownership type, the government IPFs have higher 80th, 50th, and 20th percentiles, followed by, well, actually it differs. The 80th percentile for the for-profit is second highest, but the 50th percentile for nonprofit is second highest. So anyways, the whole point of these bar charts is to give you another tool to assess differences in practice patterns that might be unique for your organization. And so if you feel like you would like to look at your statistics and compare them to something other than all IPFs in the nation or jurisdiction or state, we do give you these other alternatives. Again, on the training and resources page of our website, you'll find a lot of resources. The user's guide is out there. There is a jurisdiction spreadsheet that identifies the total number of IPFs in each MAC jurisdiction in total and also by state. We have, of course, there are recorded PEPPER training sessions. There's a sample PEPPER out there. And then we do maintain a document that just keeps the history of the target area changes and what the impact of that would be, but we don't have any target area changes for this release. If you find that you do need some assistance with PEPPER, please visit our website, pepperresources.org, and click on the Help Contact Us button, and then click on the Help Desk button. There's a form there that you'll complete, and a member of our team will respond promptly to assist you. I do ask that you please do not contact any other organization for assistance with PEPPER. We're the official source. And this is just a screenshot of our website home page. You can see that the resources for IPFs are easily accessible there from our home page with a quick link to the user's guide, the training and resources, PEPPER distribution if you need information about getting your PEPPER. You can go right there. At the top of the ribbon, it might be a little hard to see, but there is a data tab there that you'll click on to get those national level and state level reports that I just mentioned, as well as the peer group bar chart. You can find those there too. So a lot of information out there on our website.